Okay, this is a heavy chapter because we'll see lots of ramifications from this. So think about if I didn't take care of my hypertension and it led me to having angina, and that I didn't treat that angina and it got worse and I eventually had a heart attack, and that was myocardial infarction. Wherever that infarction occurred is going to dictate how my heart functions. It's not able to beat appropriately. It's not able to squeeze. Think about it at squeezing. So it's not able to contract well after that infarction. So because of that, the physiology, the anatomy of that heart changes and the function of that heart changes, and it's less effective. So I'm going to see lots of signs and symptoms that go along with heart failure. I want to point out three things. Actually, there's quite a few things in here, but I want to point out these three things because you're going to see them frequently. Inclex and Hesse and myself, sometimes they'll say something about a drug, and they'll say the chronotropic effect or the dromotropic effect or the inotropic effect. So if it's a chronotropic drug, it's going to influence the rate of the heartbeat. So a positive chronotropic drug will make the heartbeat faster. A negative chronotropic drug will make it beat slower. A dromotropic drug influences the conduction of impulses. So again, if it's a positive one, it speeds up the impulses and usually the heartbeat. And if it's a negative dromotropic, it's going to decrease the conduction, make that slower. Come down here to inotropic. Inotropic drugs influence that muscle contraction. Specifically, it impacts the way that heart squeezes, especially those ventricles, to make that good contraction. So the better I contract, the more blood, therefore oxygen, I get out to my circulation. So a couple different words. We'll pick up atrial fib and automasticity in the next chapter. What I'm looking at here is that ejection fracture, which tells me how much blood is pumped out or through during ejected from that ventricle, based on the filling volume. So how it's really kind of like what's being pumped out versus what's sitting in that ventricle. You want to pump out just as much as possible instead of it sitting in the bottom of that ventricle. And it would sit in the bottom of that ventricle if the ventricle didn't contract well because it had a myocardial infarction somewhere on that in that area. When I have heart failure, that's when my heart's not pumping effectively to keep up with how much I need. So I usually see that on the other end of a myocardial infarction. Those are my big ones on this. We'll pick up these refractory things when we get to the next chapter. I like that they duplicate that. Talk a little bit about heart failure. Kind of talked about what I just mentioned. So read through that. Different stages. I'm not going to ask different stages, but obviously the worse it gets, the more heart failure that patient's experiencing. Just making sure you understand the anatomy and physiology of the heart. And then when we look at these drugs, just like we've done before, we're going to start seeing different classes of drugs under this umbrella of anti-heart failure or heart failure medications. So we've already had ACE inhibitors. We knew the first time we saw them to watch for that dry cough and hyperkalemia. It's going to be the same thing here. My next one of those ARBs, which sometimes patients get switched to because they can't tolerate the ACE inhibitors. The benefit here is that it doesn't have a dry cough and it doesn't have hyperkalemia. My beta blockers that we've mentioned before have that OL at the end, so that signifies that's a beta blocker. Then I can have some miscellaneous ones, which we already mentioned, that Bideal in our anti-angina chapter. And then I've got phosphodiesterase inhibitors, PDIs, or cardiac glycoside, digoxin, which we'll talk about. So at least 1, 2, 3, maybe 4 of these we've heard before. So that's going to seem like it's not so much quite in this chapter because we've heard those before. So we're going to scroll through those. ACE inhibitors, we've already covered this, so those look the same. I will point out that a lot of our ACE inhibitors end in that RIL, so that helps you to be able to recognize those. Drug of choice for this one is this lisinopril. On this one, I want you to keep the same thing in mind, that it can cause hyperkalemia and dry cough. So keep those in mind. If patients can't tolerate those ACE inhibitors, we might move them to an ARB. Same thing with my ARBs on on those individuals. They're going to cause some good vasodilation. Can use them alone or with other medications. Don't have the cough and don't have to worry about our hyperkalemia with those individuals. My Valstarin is my medication for this one to keep in mind, and we don't have to worry about that hyperkalemia. My next one, let me see. Oh, here's my drug of choice for that one, my Valstarin here. The benefit of my Valstarin, this one, is sometimes I can add it with another drug to create like a synergistic effect with those. I'm going to get into my beta blockers a little bit here. We've talked about them in 2 chapters so far. So my beta blockers will decrease that cardiac contractility and causes that heart to rest a little bit more. Ends in OL, so we use that to treat that heart failure. My Cardiovail is my drug of choice for this one. If you remember, this is the one with the matrix that patients may poop out, so tell them to be aware of that. Let's see, I think I'm skipping through this one. So some of my miscellaneous ones, I want to point out the Bideal, which we mentioned earlier. Great for treatment of individuals with hypertension, angina, and heart failure in Black population. Keep that one in mind. And the new one here is my dobutamine. This one's typically given, it works really well. It increases my cardiac output by making my heart pump more positively. So increases that contractility. That's that positive inotropic response. We have to give this one IV by continuous infusion. So these patients are going to be in an ICU for continuous monitoring. Usually this is on a titratable scale. So as my patient's chest pain gets better, I can decrease their amount of dobutamine that they're on. So I play with that as how they're breathing, what's their lung sounds like, what's their urinary output, what's their heart rate, and it gives me some parameters on adjusting that based on how my patient's doing. My next group on my PDI inhibitors, we've got one medication on this one. We want to point out that my drug of choice here, that milrinone, is that inotropic support. Remember back at the beginning, that inotropic helps the force of the muscular contraction. So it really helps that heart to contract better, more fully. So we'll use this one usually short-term therapy. Adverse effect, this is, probably should highlight this one. Number one adverse effect of our drug of choice for this one is dysrhythmias. So we'll get to that in another chapter, but it can cause some dysrhythmias, and that's your NCLEX question on that one. Can also be associated with hypotension or angina or hypokalemia. So lots of negative aspects about it, which makes this not a first line of defense for individuals with heart failure. My milrinone is my drug of choice for this one, inotropic, so it helps that heart to beat effectively. Also has some vasodilation that goes back up here to that hypotension. So I'll see that vasodilation and replacement with that. Then let's look at, for final, here we want to look at our cardiac glycosides. We've got one drug of choice here. On my cardiac glycosides, they do a couple of different things. It has a positive inotropic. It really helps that heart to beat very effectively. So it by beating effectively, it helps it to squeeze effectively. And as it squeezes and relaxes, the relaxation helps that ventricle to feel, F-I-L-L, to feel good. And then as it contracts, it helps it to get all of that blood in that ventricle out into my systemic circulation. Has lots of other effects produced by digoxin. So positive inotropic helps it to squeeze, contract well. Negative chronotropic, so decreasing that heart rate. Negative dromotropic, decreasing the electrical impulse conduction through the heart rate. Helps my stroke volume, reduction of heart size during diastole, so that's going to increase my cardiac output. Decreases my venous blood pressure, increases that coronary circulation, so lots of good things with my digoxin. We use it for the treatment, you don't have to worry about systolic blood pressure, but with our heart failure and individuals in atrial fibrillation. Contraindicated with drug allergies and second or third degree block or ventricular fibrillation, or if there's a diastolic problem. I specifically wanted to look at these because we mentioned it has a negative chronotropic effect. That's why we can't give it in someone with a heart block, because their heart rate's already slow. So we want to make sure that that's not the case with those individuals. My patients with digoxin we tend to see more of an overdose with my digoxin. I don't know if it's due to individuals not tolerating it well or just taking it too frequently, like my parents would take it frequently if I didn't have it in a pill counter for them. So we need to keep that in mind. If I have individuals that have an overdose, when I have severe toxicity, we're going to give digifab therapy, which binds with that digoxin. So on my digifab therapy, we give this when an individual has hyperkalemia over 5 milliequivalents. Those life-threatening dysrhythmias that we mentioned earlier, specifically VTAC or VFib or severe bradycardia, or then a life-threatening overdoses when they read more than 10 milligrams in their blood level. Their blood level would read over 10. So on these individuals, we give them when they have their heart failure, because we're going to help that heart work well. They want to point out this clinical pearl. If I have a patient that's hypokalemic and hypomagnesemia, can predispose that to digitoxicity, so keep that in mind. Digoxin, lanoxin, that medication, we use it for treatment of heart failure, atrial fib, and flutter. We want to keep their therapeutic dose levels between 5 and 10 nanograms per milliliter. However, if I have more than, I might increase it a little bit to treat that atrial fibrillation, if it's specific for atrial fibrillation. Okay, let me scroll down to here. My digifab is what I give to someone who has a severe digoxin overdose. So we mentioned that over 10, I believe, at the top, or hyperkalemia or ventricular dysrhythmias. On my digoxin, one of the parameters on our assessment is to assess their apical heart rate prior to giving. Most of our acute healthcare facilities will require us to take an apical heart rate for 1 full minute prior to giving digoxin. Some places will even require us to chart that on that medication administration record prior to giving. You can delegate that heart rate out, but if it's anywhere close to being 60 or below, I would go and recheck that myself. So note that. You also want your patients to do this when they're home. So you're going to start teaching in the hospital how to take that, how they need to take they could even take a radial pulse, but how they need to take that pulse before they take their digoxin. They also need to be very good about setting up their pills in a pill minder so they don't overtake their medications. So for any of these, we want to make sure we're following watching for dry cough or hyperkalemia with my ACE inhibitors, monitoring if it's supposed to be a inotropic or a chronotropic or a dromotropic, understanding what those words mean. Daily weight's important with these individuals because if they have an increased weight gain, that means they're holding on to fluid. So most healthcare providers will tell the patient to weigh at the same time, same scale every day, and notify the healthcare provider if they've had a weight gain of over 2 pounds, because that means they're holding on to fluid. That would go along with our implementation for those individuals. So here's my heart rate for that one. I think those are my big things there. Remember, digifab is what I give if my patients had an overdose of digoxin. And I did want to hit up, and I didn't see it here, some of my side effects. Oh, there they are. Some of my side effects of digoxin toxicity are nausea, vomiting, anorexia, and visual disturbances, particularly halo visions, which is where they might look at a light and see a halo around it. So those are the big key indicators for evaluation of dig toxicity.